first like to ask Professor Kling to introduce himself, tell us a bit about how does his daily life look a little bit on the academic and on the private office.
Okay, it's going to be a 5-hour presentation of my background now. Actually, I have a dual appointment. I am a dean at the Faculty of Odontology at Malmö University, and I still keep a position at Karolinska Institute in Stockholm, where I was head of perio for 20 years. And I do my patient contact, patient treatment intramurally at the university in Malmö. So I basically have access to administration that takes most of my wake hours. My research interest is tissue regeneration, periimplantitis, and also the oral systemic link, but that's a totally different issue.
This morning you were explaining in the conference that you gave about posing the question of whether periimplantitis is an academic issue or whether it's a real clinical issue that we face on a daily basis. Can you elaborate on that a little bit?
Mm-hmm. You know, I think that for the clinical activities, dentists may be a little bit confused about the different messages that comes out when it relates to periimplantitis. So that was what I was trying to address. On the one side, there is one academic group claiming that basically there is nothing called periimplantitis, and if there is, the initiation of the process has to do with a so-called foreign body reaction. That is an autoimmune reaction, actually. And on the other side are those claiming that basically every implant that has been put in a patient is at risk to develop periimplantitis. And I think that, as so often, the truth is not at one extreme, it's more a balanced situation. I mean, claiming that every implant would be at risk for periimplantitis is the same thing as if you would say that every tooth is at risk for periodontitis. And yes, from a biological point of view, every tooth that has erupted is at risk for periodontitis. But as we know, it is around somewhere 7–10% of the adult population that is suffering from more tissue-destructive periodontitis that will also result in loss of teeth. And by the way, teeth rarely fall out. They are removed by the dentists. So there are a few things to be discussed there. But coming back to the conflict, the one idea now academically is that the implant is part of a immunologic reaction when it is regarded as a foreign body. And when this foreign body reaction gets a little bit unbalanced, you will risk tissue destruction. Whereas the other biologic concept is that, as with the periodontitis, you have an infection around the tooth. This infection leads to an inflammatory response, and in select cases, this inflammatory response is a tissue-destructive response. And once we have bone tissue destructed in this process, we have periimplantitis. As with periodontitis, we also have different cut-off values. I mean, what is periodontitis? Is it a 3 millimeter probing pocket depth? Is it a 4 millimeter probing pocket depth? Is it a 5 millimeter probing pocket depth? Should the deepened pocket be accompanied with bleeding on probing, with pus, with radiographically overt bone destruction? And there is actually no international consensus of what exactly is the diagnostic criteria for periodontitis. The same thing goes for periimplantitis. Some authors report on bone loss of 2 millimeters, Some authors publish on bone loss of 3 millimeters, some even publish bone loss of 5 millimeters. And of course, if you combine this bone loss with, you have to have pocket depth exceeding a certain number of millimeters, you have to have bleeding on probing. These figures can vary enormously from few percent up to 50–60%. Also, another issue is that when you read the literature, sometimes you will find that reports are based on the patient as a unit, and other reports will report on implants as a unit. And since most patients have several implants, it means that if you use the patient as a unit, you will have much higher percentage figures than if you use the implant as a unit. So when reading this and when listening to so-called experts, you will find that you are exposed to a variety of figures, and then what should you believe in? And I think that over the last few years now, we have come up with a reasonable consensus when it comes to diagnosis of periimplantitis. And given these criteria, we can say that about 1 out of 5 patients, 20% of the patients run the risk of developing periimplantitis. And if we instead use the implant as the unit of reporting, 1 out of 10 implants, 10% of the implants will run the risk of developing periimplantitis. So this is confusing, and for me the academic discussion is more of a molecular initiation of the biologic event that later results in a clinically overt disease.
We'd like to conclude the interview to ask you, you gave us some very interesting estimates during your presentation. The number of implants that are placed worldwide, if I'm not mistaken, comes up to a figure close to about 20 million implants placed a year, according to some research that you did. What is the future that holds for a specialty? We're discussing a number of incidents of about 10% of periimplantitis. What does the future hold for the specialty of implant dentistry, given the fact that we're having about 10% of these incidents of periimplantitis from 2 side points? On the one side, the prevention, how can we reduce these figures, and from the other side, the treatment aspect?
Mm-hmm. I think that with the analogy of natural teeth I just gave, you have to realize that just because you have an erupted tooth and just because you have a placed implant, they are not deemed to be lost in a tissue-destructive disease. And for periodontitis, gingivitis as the initiation, we know that the home care, the prophylaxis, what patient does themselves to avoid infection and inflammation is the critical issue for natural teeth, and that is the same thing for implants. Sometimes both patients and the profession are made believe that if you place a titanium strong rod in the jaws, that cannot be affected by caries, for example, and that is correct, but it can be affected by inflammatory diseases. So prophylaxis is the number one. And second, the supportive treatment, that you get the patient in regularly, at least on an annual basis, to promote their self-performed oral hygiene, but also to help out with the initial inflammatory reactions that takes place. That is the basis for the future implant treatment, to avoid the problem. Because if we run into adding 15 to 20 million implants per year, and out of those a few millions with problems, then we are in a big problem. So I think that prophylaxis, making the patient aware of the possible risk, And adding to the home care and the supportive professional treatment, of course, the relation to smoking. Smoking and periodontal disease we know fairly well today. Smoking and peri-implant disease is also a critical issue. So there are 3 golden rules: patient's own oral hygiene and prophylaxis, the professional supportive treatment, and quit smoking. And then you can live your life happily with your implants.
Thank you very much. We'd like to thank Professor Klinge for his collaboration and for his visit here to the Spine Society of Perio. We hope to see him again sometime soon, and we'd like to thank him as well for his wonderful conference this morning.
Thank you so much. It's really a pleasure, and congratulations, Sepa, to a wonderful congress. Thank you.